Thank you very much, everybody, for coming. Please welcome to this session about public health management. We're population health management. We're really excited to be thinking about how population health management can be health creating. That's what this session is all about. And you're very welcome. We look forward to an exciting set of exchanges. There are going to be some people who've done some extremely exciting work on the ground. We'll be thinking a little bit about the overall approach of public health, population health management, and then there'll be sessions, breakout sessions, where we'll be talking to each other so that we can really bottom out this this whole approach. So the sessions are being recorded and will be available on the Health Creation Alliance YouTube page from mid-November. There'll be a short write-up from this session that will be made available. Please introduce yourselves in the chat box. Use the chat box to share views, observations, links to resources, and so on. That's proven to be a really exciting and challenging aspect of all of these meetings. This is one of six, this is the third of 6 online and 1 in-person events taking place this week that make up Health Creation Coming of Age. And we hope that sessions so far have been good and that this one and following ones will be exciting as well. You're very welcome to join the Health Creation Alliance for free and play your part in spreading and advancing health creation. There'll be an evaluation at the end of the event, so please don't forget to complete that. So the Health Creation Alliance is delighted to be working with our partners, supporters, and sponsors on bringing these sessions together. And without them, it wouldn't be possible to bring you this set of exciting events. So our sponsors are the National Health Executive and Public Sector Executive, HLM Architects, NHS Property Services, Novartis, PPL, Solace, South Central West, and of course we shouldn't forget our patron, Lord Victor Adebowale, and Lord Nigel Crisp. So I'd like to give a little bit of background to this coming of age, and also then introduce the Health Creation Alliance so that people know a little bit more about it. So for the last 7 years, the Health Creation Alliance has led a national movement for health creation to address health inequalities. For the first 4.5 years, things moved slowly in the right direction, but COVID-19 changed everything. COVID is just one of the many destructive forces in our world today. It exposed stark inequalities at the same time as making visible some of the more hidden aspects of how communities work and how they become resilient and thrive. It concentrated minds on how inequality leads to poor health outcomes, but also on how health inequalities can be addressed by creating the conditions for communities to become strong through those connections. So the last 2.5 years have been very different. Health creation is experience what might be described as a coming of age. But there is a lot more maturing still to do. Health creation must become business as usual across all our systems, alongside our efforts to treat illness and to prevent ill health. As we move into a new phase where much broader partnerships and collaborations become possible, our collective mission must be to build back together, including with those communities who experience the poorest health outcomes, and increase our efforts to make the necessary changes happen. So at the beginning of this series of events, we are issuing a call to action for all integrated care systems to recognise health creation as equally important in addressing health inequalities as the treatment of illness and prevention of ill health, and to adopt and embed it as a way of working, making it business as usual across the whole system. So that's the call to action. We will be talking about that call to action towards the end of this meeting to see if it has changed as a result of the discussions that we're having today. So that's our introduction, and we appreciate that not everybody will be familiar with health creation. So I'd like us now to explore a little bit, for me to explain very briefly what we mean by health creation and how we expect and want health creation to be implemented across the system. So there's a slide before that, please. There we go. So the Health Creation Alliance is the only national cross-sector group addressing health inequalities through health creation. Our mission is to increase the number of years people live in good health in every community, and to ensure that health creation sits alongside treating ill health and the prevention of illness, and that it becomes business as usual across the system. So that's what we aim to achieve. Next slide, please. So what we mean by health creation is the process through which individuals and communities gain a sense of purpose, hope, mastery, and control over their lives and immediate environment. And the evidence is now really strong that the more control communities can gain, the more their health and well-being is enhanced. So that is the key concepts that we want to get across. And of course, that's not the only thing that makes a difference to people's health. We also know that people need a good job, a good home, and a realizable future. So professionals can work together to build health creation, working as equal partners with local people. And the approach that we have been advocating, and which is really very well evidence-based, is the 3 C's: control, contact, and confidence. So the evidence is strong that if you bring people together, you work with each other to build confidence, then increasingly communities and individuals start taking more control over their lives. And it's those links with other people, those social networks, that make such a difference, which is one of the reasons why health creation promotes community strengthening and the techniques involved so strongly. And we've talked to communities about what it is that makes a difference and how health creation happens in communities. And these 6 features are what they tell us are most important. Listening, but not only listening, but responding to what communities are telling us. Truth-telling, strengths focus, so not thinking about what is wrong, but what is strong. Self-organizing, power shifting, which means sharing power with communities, enabling communities to take more control. And reciprocity, which means communicating, collaborating, and working together in this kind of way. So all of us can contribute to health creation in whatever job we do across the system, whether it be in the NHS, in housing, in education, wherever, in local authorities. We can all contribute to health creation. It's a cross-sector experience. So I hope that explains briefly what we mean by health creation. And I'd now like Meren to come and talk much more, to try and explain how population health management has a health creating element and how it needs to express that in the work that ICSs do. Meren.
Thank you, Brian, for that introduction. And we're very pleased indeed to be welcoming NHS England later on our panel. Dr. Dunn Alton will be with us on this session. He is the National Population Health Management Clinical Advisor at NHS England. And so I'm going to just, Daniel, I'm hoping that you can correct any errors I make in this short piece, but in the next few sentences, I'm going to use NHS England's own language from their website about what population health is and what population health management is. So these are NHS England's words about what that is. So population health is a core strategic aim for integrated care systems. The aim is to improve physical and mental health outcomes, promote well-being and reduce health inequalities across populations, with a specific focus on the wider determinants of health, things like housing, employment, education. Population health management is a way of working to help frontline teams understand current health and care needs and predict what local people will need in the future. It uses data to understand what factors are driving poor outcomes in different population groups. Local health and care services can then design new proactive models of care. They can better tailor care and support for individuals, design more joined up and sustainable health and care services that will improve health and well-being and make better use of public resources. So that is a description from NHS England's website. And personally, I didn't see any real health creation being expressed in those paragraphs. So I just want to say at the start that I don't see health creation coming through in those descriptions. So today, we're going to look explicitly through a health creation lens. We're going to explore what population health and population health management might look like. And I'd like to come up with a new way of describing population health and population health management in the national programme and the maturity matrix, if we can. To kick off this debate, I'm going to make a proposition, and we'll keep coming back to that, hopefully through the session, and particularly towards the end, because NHS England has set out what it believes to be the core PHM capabilities to support maturity in line with the PHM maturity matrix. And these are described in terms of the 4 I's. So we have infrastructure, we have intelligence, and we have interventions, and we have incentives. And essentially these 4 I's set out how integrated care systems might expand and enhance their data analytics infrastructure to gather and use data better, to target certain cohorts of communities and deliver better services. But the proposition that we're putting is that data analytics is only one side of the coin. And if we really want to achieve the ends, the expressed ends of reducing health inequalities, then we have to focus on the other side of the coin that is currently hidden from view. The power dynamic, if we don't do that, the power dynamic between services and communities will not change. And community health and well-being will not improve, and health inequalities will not be reduced. So the other side of the coin is what I'm putting to you today. And if you want to show the slide, Neil, thank you. So this slide, in effect, shows 2 sides of that coin. The top half in blue is a summary, a very brief summary of the 4 I's of population health management. And the bottom half in pink is a summary of some of the things that we think need to happen to make this into health creating population health management. So we put those under infrastructure, intelligence, interventions, and incentives. So, you know, this is to be tested. We can develop this further, but certainly it feels that we need a workforce with skills and time to listen and to hold conversations and build trust with communities. That must become part of the infrastructure of ICSs, and a leadership capability that enables systems to respond to communities. I think that's what we mean by health creating systems leadership. And we need to, another aspect to this might be to equip communities with research skills so that they can carry out their own research and contribute to that that intelligence, and we need the infrastructure to do that. So there are some examples of how we need to develop our infrastructure to enable communities for their insight and their assets to be used here. When it comes to intelligence, we need to be prepared to share our data with communities. They can understand all of this data if it's presented in the right way. We need to seek their insight as to why the data is as it is, what lies behind that data. They will know all sorts of information that the data analytics people have no idea about. And we need to work with communities to reach those people that are not registered with a GP. So filling gaps in the data as well, because there will be gaps. So that's some of the things that we might want to look at under the intelligence. And then under interventions, there's so much communities can do once they're engaged in that conversation and energized, and are already doing in many respects and in many instances. So we need to draw on those strengths and those networks and be prepared to work with communities. We need to hold ongoing conversations with communities as things develop to see how it's going. And we need to enable communities to participate in that delivery, actually, community-led solutions. And then on the incentive side, it's just so important. Communities, this doesn't come for free. They do need investment. They do need resources. So we need to think about how we remunerate community members for those, commissioning them to do things that they know how to do well, etc., and invest in those, sort of the priority neighbourhoods, some of those places with the poorest health outcomes. And also the communities of identity, of course. So those are just that's just a little sort of summary of how we see the two sides of this coin developing. And our ask of NHS England is to take this seriously and adopt it in terms of moving to health creating population health management. And we're happy to work with you to build that and to refine the details. But for the rest of this session, we're going to hear about people who are actually doing this on the ground, and it's going to be much more richer. You'll get a much richer sense of what's happening, of all the pitfalls, of all the successes and all of that. So I'm really looking forward to hearing about the reality on the ground. Thank you very much.
That's fantastic, Merryn. Thank you so much. And I think what you can see is how the Health Creation Alliance tries to look at the nitty-gritty, tries to look at the both the principles and the detail of how things are actually developing and trying to move things in a health creating way. So that was very helpful, Merryn. And as you say, we're going to move on to listen to how Lancashire and South Cumbria are doing population health management. And I hand over to them, to Andy Knox, to kick things off, and there'll be some a little bit of time for questions at the end of this session. So thank you.
Great, thank you. I'm not sure if Andrew Bennett or I are going to introduce this, but seeing as you've handed the baton to me, Brian, I may as well just talk very quickly. Hi, everyone. Nice to see you. I'm Andy Knox. I'm Associate Medical Director, and I co-lead the programme around population health, tackling health inequalities and building health in and with our communities, with the wonderful Andrew Bennett, who's Director of Population Health for Lancashire and South Cumbria as well. And I guess we're here with the sense of trying to tell a bit of our story, but also really hopeful that in the panel discussion afterwards and also in the Q&A, that we'll get some positive challenge back to us. We want to have a real sense of humility to learn this morning as well as present. So we're really open to a positive challenge to us to help us develop this work even more in a health creation way. So I'm not sure if Andrew wants to say anything at all at this stage, but we're going to introduce four of our wonderful colleagues from across Lancashire and South Cumbria. First of all, Vicky Hepworth-Putt, who's a public health consultant working with us, and Scott Johnson, who we describe as a data whiz and all things PI. I don't really actually fully know what his job title is, but he's such a gift to us in our system. And they're going to present a bit of some of the things we've been learning in Morecambe Bay. And then we're going to hand over to the brilliant Helen Arthur and Santosh Davies, who are also working together really closely in East Lancashire. They'll tell a bit of our story, then I'll come back and summarise just a bit of our approach in Lancashire and South Cumbria And then we're going to open, I think, to Q&A, which Andrew will help facilitate before we move back to kind of a panel discussion and a reflection on our work. So hope that's helpful. I'm really excited to talk to you about this together. I'm going to hand over to Vicky and Scott together now. Thank you.
Thanks, Andy. I can see Scott isn't spotlighted with me, so I'm wondering whether he's dropped off because his internet was being tricky.
So I think he has. We've got to Scott Morgan's, but not Scott Johnson. So I think he must have dropped off. Unless he's got the
what different... a data whiz he's turning out to be. We're just showing off now in Lancashire. Vicky, are you okay to kick off with stuff? And if Scott can rejoin us, then brilliant.
Yeah, that's fine.
Yeah,
I will do my best. So my name's Vicky, as Andy just said, and I am a public health registrar. So I'm an acting consultant, and I'm really lucky because I'm based within the local authority, but I'm embedded across the NHS. So I work with the ICB and with our local trust around population health and public health. So primarily with a focus on reducing preventable ill health. So that's looking across the whole spectrum of prevention, from the social determinants all the way through to supporting people who are already unwell to ensure that they get the best out of health and care services. So it's a really privileged job, actually. I love it. So I'm here today to chat to you with Scott, who's not here unfortunately, about how we used population health management in a work stream to try and improve outcomes for people who are admitted to hospital due to alcohol misuse. So we had some data locally that showed that our hospital admissions due to alcohol misuse were much higher than the national average, and we knew it was an area of concern for us, and we knew that it also exacerbates health inequalities because people who are attending hospital for that reason quite often live within the most deprived communities and quite often experience the poorest environments for health. So it's very difficult for them to make change. So we were really committed to try and put something in place to help support them with their outcomes. So we were in the process of doing some work across the local authority, the NHS, community organisations, including our voluntary sector, to try and explore what we could do differently to support people who were admitted to hospital. So this is where Scott came in, because as part of those conversations, Scott was doing some analysis around A&E attendance, and for the people who have the highest intensity of attendance as well. So people where we're obviously not quite doing what we need to do to support them as best we can. So they're coming back into services. And he identified a really clear cohort of people that we needed to support better in relation to those hospital admissions. So as part of those conversations that we were having across the system, plus the public health data, the population health management data, and some feedback that we had from staff and patients around what they would like to see to support them, we commissioned a local lived experience recovery organisation called The Well to assertively in-reach into the hospital to support local community. So the work that Scott did greatly supported some of that work because it highlighted the people that we needed to target. It also enabled him to have a really good conversation with The Well to share that data, but also, most importantly, to get the insight from The Well about who those people are. Now, this slide has just come up, but I'm going to hope that Scott's back online to talk through it rather than steal his thunder at this stage. So basically, we commissioned The Well, and The Well are an amazing organisation. So they are a community of people who provide support to recover from substance misuse. So not only do they work across the community to provide hope and totally share that belief that anybody can recover, they really importantly work to improve the environment. So they create for health by ensuring that people's housing is adequate, they provide them housing where necessary, and they provide really amazing pathways through to employment. So they help with the recovery, but they also help with those conditions that enable recovery. So it's absolutely essential. Thank you for putting that in the chat. So they've been doing this work for a couple of months, and in that time they've already helped 31 individuals to be a part of the well. I went to see them a couple of weeks ago, which was a privilege for me to be allowed out, and they were remarkable actually. And one of the guys there says that their inReach has saved his life, to be honest. And none of that would have happened without the whole jigsaw being in place. So the jigsaw being public health data, population health management data, system working across all of the organisations, input from the community, some resources locally and nationally to enable this to be delivered on a sustainable level. This work had been piloted before, but never done on a kind of recurrent funded basis. And it's real testament really to how we can work together in population health and public health to make a difference for the communities that need it the most. So of those individuals that have been supported upon discharge, so the well go into the hospital, they provide bedside support, they hold their hand basically when they leave the hospital, they help them to go to mutual aid if that's what they would like to do, they help them go to the drug and alcohol services if that is what they would like to do. They basically support and wrap around support for individuals to make sure that they have every opportunity to recover. And they are most definitely a community that creates health. So from our perspective, it's really important that we use all of that intelligence to support organisations and communities like this to function, because they are the ones that make the difference and they are the ones that can help the individuals to create health. So I think it's really, really important. And unfortunately, Scott's not here, but what he was hoping to say was that as part of that analysis that he did through A&E data, he met with the well and shared that information, obviously all anonymised, but just by sharing that information, the conversation between Scott and the well highlighted that the well were aware of some of the patients that Scott was describing and were able to proactively, following that conversation, contact them and support them even more further to try and reduce their attendances. And you can see that from the data, attendances have been reducing over time, and that's not solely because of what I'm talking about here. And I suppose that's another important thing to take home from this, is that everybody's different. Sometimes with data, we think about populations as being homogeneous, and they're not. Everyone's an individual. So we need to put in place multiple different interventions to support people, so that we're providing support in the way that they need it. And that's why the engagement's so important, so that we can understand what they need, but also so that we're monitoring the impact of those evaluations so that we know what works. And I think that's me. Apologies if that was a bit jumbled, but with Scott's absence, you've only got part of the story from that, I'm afraid.
Great, Vicky, thank you. And I think one of our biggest pieces of learning has been, hasn't it, just the humility to recognise the NHS and even public health, we don't hold all the answers. Actually working with the lived experience recovery organisation of the well has been massive in terms of their ability to build and create health with a community of people, because they're all people who've come out of heroin or crack cocaine or alcohol addiction themselves and have created this incredible recovery community that they actually bring people into. So then they create health together as community. Yeah, it's been a really brilliant learning journey for all of us, working differently and being willing to to recognise that some of our traditional ways of trying to provide alcohol and drug services were not as effective as maybe some of learning to work differently with a lived experience recovery organisation. So, but that combination of data, then really listening to the community, sharing that together, and then creating a different approach has been really, really wonderful. So thanks for sharing that, Vicky. Absolutely amazing. I'm going to hand over to Helen and to Santosh now, who are going to talk about some of the work we're also doing in East Lancashire.
Thanks, Andy. I'm Santosh Davis. I'm a GP in Burnley Wood. I and Helen are going to talk about our journey in Burnley Wood and one of the most deprived parts of East Lancashire. Our journey started a bit early in 2014. We noticed that.
I'm sorry, it's Santosh. It's Neil here. Could you tell me what name you have registered under in terms of your the name? As you see down here, Helen has at the bottom left-hand side, because I can't seem to locate you on the list.
It's Dr. Santosh Davis.
Ah, got it. Okay, so it's down as doctor. Let's have a.
Okay.
Got it. Thank you.
Okay, thank you. So our journey started in 2014 when we noticed that our population was struggling to meet its health needs. And most of the health needs were beyond health. It was other social issues which we had no control over, sitting in the four walls of the surgery. So interestingly, I was a member of the local CCG, and the public health managers used to come and talk to us. And interestingly, they were always given the last slot to speak, and by the time the meetings always overran and everybody walked away, leaving the public health manager talking to himself or one or two people who were left behind. And one day I stayed behind and said, it was Melusi, I said, can we do something about it? I know you come with all the statistics and numbers and figures that Burnley is doing bad. It's not the greatest numbers we are saying. So can we make something out of it? So actually we had no idea what to do, but we knew something has to be done. So on his suggestion, we decided to meet with people around us and say, what does they need and what can we do? So we started having individual meetings with the church leaders, imams, the housing association, and Burnley has a football club. Unfortunately, we dropped down a bit to from Premier League. But this is a home club. So we met with the Burnley Football Club. We met with the community centers, local leaders. We met with everybody we could meet. And interestingly, we said, let's do something. And we didn't know exactly what to do, but we said, let's all come together. And our patient participation group also helped to connect us with the local leaders. And this went on, and then they said, let's put a date on the calendar. See, we had a grand meeting organized in one of our community centers. And I was ready to change the world. And I said, everything is going to be perfect. And that's right. And the first meeting, if I say, was a disaster, if not more. Everybody questioned what's going on here. What does a GP has to do in this community here? And some said, we know our job. We have been doing for long. What do you want to do here? So it was a meeting I wanted to forget, came back feeling upset, saying that, what is my role there? Everybody was questioning, looking at me with suspicion. And this was 2014, where social prescribing was not the in thing. I came back, theoretically, actually I cried in the room, said, what did I do? It was actually the time I thought I should give up and move on with my life. It's nice, nothing's going to change. But something said, no, I maybe approached it wrong. So furthermore, much more coffees later, we decided to start all over again. And this time I said, it's not me that's important, it's others. And it's they are the ones who are going to make a difference. All I need to be is there behind them to make sure they're all connected, use my relationships to build up things. And that's how we started again. We developed very close relationship, and later we called ourselves Burnley Wood Community Action Network. We supported each other's bids. We came each other to support each other's causes. We knew that there is a lot of services each of us can offer, and we need to promote each other through this. So some of the pictures you're seeing is what all things we had done. We had a celebration of the community, which included the big lunch where a lot of people came. what we tried to do was promote the services available in the community, and also use as an opportunity to what the community wanted, not what we wanted. So we got everybody together. We started talking. We started having events. We had a Burnleywood Lantern Festival where kids made lanterns. We paraded all around town. And then we started discussing things openly and honestly with the population, asking them what they wanted and what they wanted us to do. And that's how we have done till now. So we started supporting each other. We believe we are on the right track. We've done a lot together. There is a lot more to do. And the population health approach, which is data enabled, delivered in the community, by the community, and for the community, is a big step in the right directions. Now, we are in the process of going for enhanced health check, which Helen is going to talk through, but we're going to use our relationships in the community to deliver these services better. So let me pass to Helen, who's going to take you through the next bit.
Amazing. Thanks, Santosh. So hi, everyone. My name's Helen. I'm the Programme Director for Population Health in East Lancs and Blackburn with Darwin, but I've got a bit of a dual hat, as most of us have in this system, actually, as the ICS lead for something that we're calling the Enhanced Health Check, which I'm going to just chuck you through a whistle-stop introduction to, so bear with me. So zooming back out to kind of system level, I guess, for a second, from the kind of real community example that Santosh has just talked through. We've got
Helen,
so much...
Sorry, Helen, can I just ask, would you like your slides now?
Yeah, that would be brilliant, actually, if that's all right.
Thank you. Thank you. Okay, brill.
So apologies, this is quite a wordy slide, but hopefully it will give you a little bit more intel and we'll talk through it. So we have, as you've just heard, we've got some great learning across the ICS, and you've heard just a couple of examples of the brilliant stuff that's going on across Lancs and South Cumbria. And what we really wanted to think about is how we could instigate a system-wide initiative that we hope will further embed a health equity approach to the delivery of services, particularly in primary care, but with a focus on partnership working to address clinical and social vulnerabilities in our communities. And this is what we're calling the Enhanced Health Check. So across Lancashire and South Cumbria, you've just heard a bit about Burnley. We've got some significant areas of deprivation, and whilst we've got some really strong, thriving areas and some of the most beautiful countryside in the country, the healthy life expectancy for many of our population is just not where we want it to be. So our aim has been that we case find amongst the groups that we know statistically are most likely to experience worse health outcomes and access to health and care services, specifically those in the core 20, so the top 2 deciles of the indices of multiple deprivation, and or those with severe mental illness or depression, so that we can provide support to address the wide set of factors that might lead to poor health and well-being. So where we started off is we kind of worked with using the local authority commissioned NHS health check as our starting point. So that's the standard NHS health check that most of us will have been called for if we're over 40. So it's for those aged 40 to 74 with no known conditions. And we've developed an approach with partners in public health that wraps around this check and covers a wider range of questions on other areas of clinical vulnerability, but critically includes social vulnerability as well. So looking into things like isolation and food or housing insecurity to really just look at some of the social determinants as well as the clinical determinants of health outcomes. So having worked with public health to set a framework across the system to deliver this, which includes a coded template in EMIS to capture findings and ensure that we're able to refer people onto the kind of relevant clinical pathways. We're also providing funding to local areas to bring in the capacity needed to both deliver the health check, but support to make sure that there is follow-up support available. And I'll talk more about that shortly. But we're now sort of at the space where it's over to places and neighbourhoods to start developing and trialling plans that will help them meet the needs of their community. So using this general framework, actually really making it specific to their own areas. And this is where we can really capitalize on the kind of work Santosh has just talked about, where we know we've got these really strong relationships between local teams and their communities, and whether that's GP-led, so primary care networks, social prescribers, but actually where it's a partnership between the kind of voluntary and community and faith teams and the types of organisations that Vicky was talking about that just really know the parts of our community that need the help. So where we've invested time getting to know our communities, we're able to really flex this approach. And I guess what we're trying to do is help other areas that maybe haven't been able to do that so well start doing more of that. We're really fortunate in that we've got multi-year funding for this approach. So for this year, it's really about building the foundation. So we are here is sort of in the spirit of sharing as we're just setting out on this pathway, really. And what we're doing is encouraging local teams to see this as an opportunity to try something new and adapt and learn as they go. So as Santosh says, sometimes you don't get it right on the first go, and that's okay. That we kind of need to try those things. So we're really encouraging them to think about setting aside proper time and the right expertise, and sometimes that's just personality types, isn't it? Who are able to draw out in a solid and supportive conversation with an individual. How are you? What's going on for you? As what you're looking at both the clinical aspects, but as we said before, that those kind of wider social aspects. We're also encouraging people to think about how we target individuals. So things like thinking about not just sending a letter out or a text message to call people forward like we would for a standard NHS check, actually thinking about, how do we find these people and how do we work with them? And then looking at timing and location of the health checks. And lastly, we're really encouraging people, because this is sort of largely PCN led, to draw on the full might of local partnerships to ensure that there's capacity for that onward support that's going to be needed. So whether that's referring people into weight management or housing and debt advice, but also making sure, if those crucial services are underfunded, actually we redirect some of the funds to those areas to make sure we are able to help where we identify that need. So as I said, we're kind of at the foothills. We've got a system framework. We've got local delivery plans just starting to trickle in, which is really exciting. So already we're starting to see some really creative partnerships in action. So Santosh is doing some great work with some of the faith sector in Burnley, working with some of them that provide support for homeless communities and rough sleepers. In Blackburn, we've got a great example of a public health and wellbeing team working completely in partnership with the GP Federation there to make sure that we've got a holistic wraparound service that brings in all of the social prescribing support that sits within the local authority teams, which is amazing. And in West Lancashire, they've already started running some trauma-informed community clinics, which are stationed next to food banks. So they're really focusing in on where they might find the people who need help more than others. So for us, in our kind of newly in our ICS journey, this has been a really positive project to start with, partly because we've had this kind of real collaboration between health NHS teams and public health at a system level in the development of the broad principles, but actually it's drawing in a much wider group of partners in the way that it's delivered. And as someone who's new to the system, so I joined back in February, it's really brought to life for me in a really humbling way the incredible passion and dedication to communities in the people that serve them in this system. And I'm sure it's much the same in others, but people from the NHS and the local authority teams, right down to some of our kind of voluntary community and faith and social enterprise teams, which actually are just holding up so many parts of our community. So it's really exciting to see where they're going to take this work next. Lastly, we're in the process of developing an approach to research and report how we find out actually what's working in these spaces to capture the richness of the learning as we go and use this to shape work over the coming years. So I guess watch this space. I think I'm handing back to you, Andy.
Thanks, Helen. Yeah, just literally a super quick 1 minute from me. If we could have the next slide as well, please, just to kind of give an example of how we're trying to work across our whole system to develop this approach. So we call this our hexagons, and we're actually now changing it into a quadrant, which is most unhelpful for trying to, but people know about our hexagons a bit already. But if we're going to build this kind of approach of health creation in and with our communities, we think that there are some really key things that need to be developed. And this is the model we've been running with for the last couple of years. So you need that kind of real intelligence and infrastructure in place. So our population health, what we call our engine room, all the data, the analytics, the stuff that flows in and helps us see at a macro level and right down to street level what's really going on in our communities. But then having the humility and the recognition to go and talk to our communities, because the data is about them, it belongs to them. So sharing it with them and saying, does this feel right to you? This is what we think the data says about this community, but what are the stories? What's your real experience of living here? And then beginning to build a social movement together with our communities, absolutely at the heart and the core of what we do, to begin to change the story, so that we're working with them, very much an ABCD approach, asset-based community development, but more than that, sometimes ABCD to me almost feels a bit usury. We're actually trying to say, what are your dreams as a community? What are your hopes and your visions? And how can we support you and work with you to create that kind of experience of life together? And so as we've shared data with communities, rightfully, they get quite angry and outraged by the reality of what they're living with and experiencing. And part of our work together with them is to challenge the inevitability of that and then to create moral alternative economies. But to do that, we have to make sure that we've got the right people in place who are resourced to be able to work with our communities differently. So in every single one of our PCNs, we have a health inequalities clinical lead who we pay and give time to, but we also then disproportionately and unashamedly have shifted our funding model to make sure we put more resource and more help into communities who are experiencing significant social injustice, inequity and inequality. And then together with our communities, we then co-design new approaches to creating health and well-being. So tackling social and clinical vulnerability together. And each one of our PCNs will work with the data and with the communities to design projects and ways of working in and with our community voluntary faith sector, with our schools, with our public health teams, to really join up an integrated approach right in our neighborhoods to begin to change this story together. And then in all of it, we're trying to wrap research around that to see what kind of difference we're really making. So that's kind of a summary in literally like 1 minute of our overall approach to trying to do this work in Lancashire and South Cumbria. But you can see how in Barrow that actually ended up with a project around alcohol and drugs. In Burnley, it's ended up around us working really creatively and differently with the community there, and then developing an approach to enhanced health checks, which is now spreading across the whole of Lancashire and South Cumbria. So hopefully that gives you a bit of a flavour of some of the stuff we're up to. And I think Andrew's now going to help us take some Q&A.
Thanks, Andy. Thanks, everybody. I'm conscious that we're working to a timed agenda today, so we've probably got about 5 minutes and then there's a panel session to come. Colleagues in the Lancs team, there are 1 or 2 questions in the chat that we'll perhaps just pay attention to. After this little point, we can answer a few of those as we're going along. Can I just ask if there are any further points that people wanted to raise at this stage?
It's Brian here, just to say you've got 10 minutes. You're absolutely up to time. It's fantastic work. Well done.
Okay, so we'll pick up the questions in the chat, but is there anything else anybody wants to ask at this stage? I can't see any hands at this point. Brian, I don't know if you can. Let me just pick up, Brian asked a number of questions as we were going through. Helen, one to you was around whether the work that we've done on enhanced health checks could be shared at this point. I wonder if you could comment on that, please.
Yeah, absolutely. So we've got a few documents that talk about what it does. We've also got the template itself, which we could share around, and we'd love to see it stolen in other areas if it's useful.
Thank you. Thank you. Andy, Tom Griffiths is asking a question about, the distinction between talking about this at system level and talking about it at an individual level. Do you want to just say a little bit more about that, please?
Yeah, absolutely. So, Tom, that's a great question. It really matters, doesn't it? Actually, this matters to people's lives and working. So part of it comes through a very different kind of listening and a different kind of way of working. So right at the heart of how we work is something called the art of hosting, which is about seeing leadership as hospitality rather than heroism. So we're not trying to come in and fix everyone's problems on the white horse and be heroes. We're trying to hold a space to bring together complex questions and bring communities together to begin to answer those. And also we do really, really deep listening through stuff like the Poverty Truth Commission. So really allowing the stark reality of people's lives to impact us and change us so that we begin together to work differently. So for example, if we thank you for the question about people with depression. So one of the things we did in my town in Carnforth, for example, is we listened to and had conversations with over 1,000 people in my town. And one of the things we heard consistently was there's nowhere for people who are struggling with their mental health to go in a non-stigmatized way and just sit and actually create a sense of self-support. And so they asked if people who were struggling with their mental health, particularly one lady who really lives with a long-term significant depression, asked if she could set up a cafe. And one of the local churches said that they could use their building for free. And now there's a cafe that runs in our town that's been running now for 7 years, where it's open for people who are just struggling with their mental health and just want to turn up and just have a bit of mutual support and chat with people. And actually what the data showed us that people actually started using their GP and coming to the GP less, because there was a sense of mutuality and self-support for people who were struggling with depression or long-term mental health illness. So it's actually about listening, being willing to respond to what people actually want rather than what we think they want, which is not necessarily more and more services to respond to ill health. It's about creating more support for people living with mental health issues in a way that works for them. So that would be one just small example of something that we've done.
Thank you. I can see David's hand and Nigel's hand. David, do you want to go first? I know you put something in the chat as well.
Yeah, thanks, Andrew. I sit on a housing association, social housing association board, which is a rather large one, called Clarion, and they have a lot of funding available for resident support and engagement. And I always think it's quite a shame that the NHS don't make more use of housing associations, because they are an excellent route into people's main problems. And as I said, a lot of, if you ask the community what their main issues are, it's usually the first answer is housing. And the NHS doesn't seem to be addressing that at all. Have any of these projects been in contact with housing associations, and were they successful?
Yeah. David, I don't know if any of my colleagues want to comment. What I'd start with is to say, I think the NHS has a lot to learn about its relationships with housing in the broadest sense and with housing associations specifically. In my experience, it's not been an area where we've built a deep relationship. So I think over the next 4 or 5 years, that's an area for us to concentrate on, but to do that effectively with our local authority colleagues as well. So you know, I think we know that we've got more to do constructively in that area. I'll see if any of my colleagues want to come back on that as well.
Yeah, it might be worth bringing Sarah Baines, actually, who's with us from Morecambe Bay today. She's doing another session with the HDA this week. But Sarah, do you want to come in and talk about some of our experience in Morecambe Bay of working with the housing associations? And we could touch on what we're beginning to do in Blackpool as well.
Well, that was slightly unexpected. Thank you, Andy. I was just sat here listening quietly to all the stuff that you were saying, the wonderful stuff that's happening. Yeah, so I work in one area of Lancashire and South Cumbria. I work in the Lancaster district as part of an integrated care community that was set up 7 years ago by the CCG there. And over the last 7 years, we've built a huge partnership. We work with members of our community. I'm fully aware of all the projects that Andy and everybody's just talked about. There's hundreds more that I could tell you about, but we haven't got time today. But yes, one of the things that we do is we work really closely with our local council and our housing associations. We have multidisciplinary team meetings. They're invited to all our community meetings, our community conversations. We're really, really working closely with them on everything that we do, every project.
Thank you, Sarah. So a bit further advanced than I perhaps implied. Nigel, we'll give you the last question, if that's okay, and then we can keep to time for Brian.
That's more than okay, and my thanks to everybody for those wonderful stories, because while I am at heart a data obsessive, given that I run a data analytics company, I think I understand that the data is one thing, but really it's the stories that are so important here. And you've done such a brilliant job this morning in making that data come to life and telling us stories, which I'm sure will resonate with many of our day-to-day experiences. I just wanted to ask the question around that fantastic work that you did with the people in the well, and how you managed to sort of link the great work that Scott has clearly done in terms of his data wizardry, if that's a word, and then linking that to the work of the well people in actually reaching out to those individuals and making a real impact in their lives. I think you said, people's lives have been saved by this work, and we should not underestimate the power of that story. I guess my question is linked to how you took that aggregate anonymized data, took it to the well people. They then, I think their reaction was something along the lines of, I don't want to misquote you, we think we know who those people are, and they then reached out. How did you do that linkage between the anonymized bit and then what I would call in my industry the case finding bit? Because I'm suspecting that there's some IG that there's maybe related to that, and I don't want to rat hole down IG, we haven't got enough time, but I think you understand the question.
Vicky?
Scott had that conversation, but based on the conversation I've had with Scott, the well, as the same as many of the community voluntary faith sector organisations, know their communities really well, and I think that was the key to it. Scott will have shown similar data to what you've seen today in terms of the patterns of A&E use and the demographics in terms of age and sex and things like that. And that was enough, to be honest, for the well to be able to work out who it was. So there was no IG issues, but it's more a reflection that the community services have far better understanding of the people that they support than I do, certainly, because I'm so far removed from it all. So for me, my job is to kind of provide that data to those services so that they can use that and add it to the insight and understanding and knowledge and awareness and compassion that they've got for those communities, and then run with it, to be honest, because they know what is needed, and it's my job to try and support them and ensure the infrastructure is there to enable them to do that to the best of their ability. So the data is part of the story, but their insight and knowledge and the people that they are, to be honest, make the difference on the ground to communities for me.
Thank you, Vicky.
Really
Thanks,
helpful,
everyone.
thank you.
Brian, may I hand over to you again, please?
Yeah, that was a fantastic discussion. Thank you very much for the questions and for the answers. And now I'd like us to move on to the panel session. So some of the characters you've already met will be in this session, but there are also new people to join us. And the question that we're setting ourselves is, why is community insight and community power still the poor relation, when it is actually the key to creating health? What can be done to redress the balance? And I think I'd be keen if you could also consider in the discussion Ollie Hart's question, which is, how do you ensure that your data hub emphasizes a strengths-based approach? There is a risk that you focus, and data in general identifies what's wrong rather than that what's strong. And I don't think anybody quite got to grips with that. So if you could consider that in the discussion, what I'd like you to do is to just give a 2 or 3 minute introduction to what you want to say about this topic, and then we can start talking in a free-moving way, and I'll be very happy to take questions and comments in the chat or involve other people in the discussion as well. So on the panel will be Andy Knox, Asmina Rentula, Dan Alton, Durka Dougal, and Nigel Sloan. So Andy, would you kick off if just a couple of minutes to set up or to say what you feel about this issue?
Yeah, I guess two main points. One is we absolutely believe in the power of community data. So we know that data is really, really important, hard data, but it only shows as part of the problem, and is also does tend to be quite negative in terms of what it displays for us. But I think the magic comes in actually then sharing that data with a community and saying, but this isn't your full story, is it? What is the story of this community? Tell us what's beautiful and amazing about this community. So we actually then create the positive story actually from within that community. We do a lot of what we call appreciative inquiry. Tell us what's amazing about living here. Tell us what's brilliant about this community. Tell us what you love about living here. Tell us what the dreams are for the people of Barrow-in-Furness or the people of Blackpool. What would you love this town to be? So then it's listening to the stories, and we're developing an approach called community journalism in conjunction with a brilliant sociologist at Lancaster University called Jenny Pope, who's doing work globally on the power of communities to be able to tell their own positive story, and how you then integrate that soft data, it's not soft data, it's proper data with soul, into your other data to begin to create a different story. So I think it is something about how you share data with communities. You do actually want to tell the truth. I don't think we want to shy away from the difficulties and realities of the pain and the injustice of what many of our communities live with. But what we don't want to do is then go, so this is an inevitable story. What we do is create the new story together with our communities. And I think the stuff that Vicky was just sharing is a brilliant example of that, is actually where are the strengths in your community to affect change? So we knew of the Wells reputation. They're one of the most successful rehab programs in the country, and yet we were hardly working in partnership with them at all in the NHS or public health in terms of the services being provided. So when we went and shared with them what we thought we knew about people who were attending our A&E or ED departments with drug and alcohol issues, not only did they already intuitively know from their own tacit knowledge of who these people were, but when we then said to people lying in our hospital beds, would it be okay with you, instead of referring you to drug and alcohol services, if we actually invited someone from the Well Inn to come and see you in hospital and walk out from this hospital with you? They knew of the Wells reputation, and they welcomed in. So that's helped us get over some of the IG issues, is that we asked permission to people who were then in our hospital beds, would you be willing to work with this amazing organization? They said yes, and then the journey began to change. So I think it's about how we work with the story, and recognize what the community assets and strengths are, and begin to join those things up to create a much more positive story of social change. Those are my thoughts.
Thank you, Andy. I really like the idea of data with soul. That is a really nice...
that's Bola Owolabi. That's not me, that's Bola Owolabi.
Still impressive and nice. And I think the issue of appreciative inquiry is really important, isn't it, as a way of getting the assets of a community and building on those as a technique for population health management. So it'd be nice to see other examples of that elsewhere. Asmina, could you introduce yourself and say what you think about this issue?
Excellent. Thank you so much. And thank you to the Alliance for inviting me to be on this platform. I am going to be a disruptor here. So if you don't mind, I would like to be a little bit controversial. You all talked a lot about data, and I'm going to say really and truly, do I want to give my data to you? And I would say no. So up till last year, I was very happy to share all my data. But from last year, because the people who were working with me wanted so much data, I said, definitely, no, I am not going to give you my data. And the reason for that is very simple. A lot of us are homeless. A lot of us don't trust organizations. There is no trust. There is no relationships. We may be going through homelessness. We may have conditions that even our own families don't know about it. So they are taboo subjects. Domestic violence, absolutely. Again, why are you collecting the data? What are you going to use it for? Let us know. There are lots of examples I can give you, but the two examples I would like to give you in just a couple of minutes is one, an organization was commissioned to help communities deal with COVID and then COVID vaccination. That organization refused to work with us, the people who did not want to give data, because they wanted to collect data and intelligence. And a lot of us don't want to give data. So they've refused to work with us. So a lot of money, absolutely a lot of money has gone to that organization. But for me, it is you have increased inequalities here. There is no equity here. You have left a lot of people behind. Then there was another organization with a little drop of money was brought together, and they brought the community people together, mostly women over 55, and said, let's work together doing some forest skills. There were people with various conditions, bereavement, all sorts of things were going on in people's lives. But what we wanted to do was bring together people so that we can help each other out. So that is your asset-based. We worked for 12 weeks together. We were taught how to use knives and light fires and do all sorts of wonderful things. But what was important was our health, our mental health and well-being. We did walks around the little forest. And people only talked about their condition when they felt comfortable. And they didn't have to talk about it if they didn't want to talk about it. So to me, there is a little bit of disruption here to be done. Shall I leave it at that? Thank you very much, and apologies for the disruption.
No apologies required. Thank you very, very much. You've stimulated and challenged us. And I think this is really at the heart of population health management, isn't it? Are we just sucking people dry of data and then using it on behalf of the organizations, not on behalf of the populations? This is the kind of question that I think we have to address. I get the sense that the examples that we've had from Lancashire and South Cumbria, that would be unlikely to be the common theme, but it's absolutely essential that we look at population health management as a collaboration between communities and public health and data scientists in particular. So thank you very much, Azmina. Dr. Dan Alton, can you introduce yourself, please, and give us an introduction to what you think about this issue?
Thank you very much, Brian, and thank you all for having me here. My name is Dan Alton. I'm a GP in Berkshire. I'm National Clinical Advisor in Population Health Management for NHS England, and I also work locally in our newly created integrated care system, Buckinghamshire, Oxfordshire and Berkshire West, as a Chief Clinical Information Officer. So I've been studying and interested in population health management for quite some years, and it's certainly at times been a bit of a buzzword, the next new thing. And that's dangerous sometimes, because people can think, well, population health management data can solve all of my problems. And as we've heard from Andy and colleagues earlier in this talk, data is very much not the key element that makes population health management work. The key element in my mind that makes population health management actually create tangible change to improve the health of our population and create health is that cultural change, that shift where we are, yes, using a slightly more data-driven approach, and yes, working in a more holistic infrastructure involving partners from across our communities. But it's almost something deeper than that. It's almost something, as Azmina very eloquently put, it's to do with building that trust. And if you do population health management correctly, you start building that trust that allows all sorts of things to flourish, be it communities and citizens being happier to share their data comfortably, knowing that it's going to be used for good to improve population health and create health. It's about working together as equal partners rather than in a traditional hierarchical system with traditionally the clinicians and NHS managers being, up here and everyone else being down there. You know what I'm talking about. You can see it sometimes in the historical meetings. We need to move past that and work in a true partnership. And I think it's those cultural changes that can really make a big difference, not just in how we manage the cohorts of patients that are being supported through these processes, but how we do business within our communities and across health, social care, the voluntary sector, communities, patient groups, faith groups, and so forth. The other thing I wanted to mention really was from a personal perspective, the fascinating experiences I've personally had working in population health management. So we talk about the PHM cycle, and it can be rather formulaic. And you start with data, you look at data, and by you, I mean professionals with the community and others. But you get to a point where data only tells you a certain amount about what's happening out there, so to speak. It really scratches the surface, but it doesn't help you understand the lived experiences of your community. And what I found to be personally a great privilege is, as a GP, I can pick up the phone, I can call up my patients, I can call up community leaders, I can speak to our local police officers and so on, and I can say, what do you think about the huge increase in, as has been outlined in the chat, mental health presentations and depression? And I can begin to understand those lived experiences a little bit more, at least to a limited extent. And then you start being able to work together in that cultural context I was mentioning to really help build solutions from the bottom up, embedded within your communities and led by your communities. And I can certainly give some local examples in terms of mental health if we have time, and as to how that works in practice, certainly in my area. To your final point, Brian, about strengths-based approaches, it's so important. It's the other side of the coin of looking at your data and identifying cohorts of the population who are not doing well. That is important, but you also have to look at the cohorts and groups of your population that are doing well, because you need to learn from that. What has gone right, not just what has gone wrong. If you fail to use that strengths-based approach and you only look at where things are going wrong, you miss out half the potential benefit of a population health management approach. So once again, thank you for inviting me, and I'm very much looking forward to this discussion.
Sorry. Thank you, Dan. That's very helpful. The question we're hoping to address is why community insight and community power is still the poor relation. And I think you must have some influence over NHS EI about this. So I think we are hearing that much of the population health management is data-driven, is not involving communities, is not, it is sucking data out of communities rather than working with them. What can you do to make a difference and to actually shift population health management towards the kind of health creation that we've been talking about today?
Absolutely. So obviously I'm here representing NHS England. I am not a director at NHS England, so I should point out my level of power over this is such limited. But I think there are a few things we need to do. Clearly, we need to recognize the power of communities, as you mentioned, and perhaps consider strengthening the messages we give. Now, population health management is an interesting challenge to try and implement from a national perspective. What you don't want to do is say from a national perspective, this is how you do population health management to your populations. What we want to do is try and ensure that local communities are leading this. So the approach that NHS England has taken to try and develop population health management has been slightly different from certain other approaches. Yes, there's some guidance, and yes, there's websites and so on, but the main thing that we've tried to achieve is something called the Population Health Management Development Programme, where we have funded time, and yes, this funding has been devolved down to organisations, previously CCGs, now ICBs, to use as they see fit, not being so prescriptive, but we funded time and facilitation and a collaborative network to try and give the headspace for local organisations to develop their own bottom-up population health management approach, working with communities. Now, Andy and colleagues have gone through this process and hopefully can feed back on it. But I think what we need to do now that the population health management development programme has been has gone through almost all systems have had this chance and taken it up. We now need to strengthen the stories that we're telling, like those stories in Lancashire and South Cumbria, which can help other systems understand that unless you work with your communities and unless you strengthen those relationships, population health management is less likely to succeed. And as has been mentioned previously, those stories, that community journalism, as has been put in the chat, is often more powerful than anything NHS England can kind of create as a big, long, complex document that goes into lots of in trays. So I think that community strengthening is so important at this point in the journey.
Thank you very much, Dan. We'll hold you to that, and the Health Creation Alliance would be very happy to think further these things through with you. Durka Dougal, please come in. Please introduce yourself, and it's a very interesting discussion. So interesting to know what you have to say.
Thank you. Lovely to be joining you. Lovely to see colleagues I've seen not too long ago, and to meet new colleagues as well. I have the great pleasure and privilege of working with Lancashire and South Cumbria, and with Dan in other ways and other examples too. So I'm Durka Dougal. I work at the King's Fund as a Senior Consultant Programme Director. I lead much of our work on population health. It's really a privilege to be able to go across the UK landscape in many ways and see amazing practice, amazing people and colleagues. In terms of this discussion, therefore, it's an interesting, there's a couple of points, I guess, in response to yours that I'll just throw in to start off with. One is the terminology that we're using. We keep flitting between, and I'm loving where it gets to, and then we almost flip back. So that notion of population health and population health management, as Meryn beautifully set out, and Dan, you keep coming back to, and Andy and colleagues, you've really shown in terms of your examples. So in a way, simplified, population health management is a data-driven tool. Population health is the goal, it's a purpose, and it's an ongoing iterative thing. It's, in a way, it'd be foolhardy to think there's an end point that we get to, because it's an iterative thing that we just want to keep growing, developing over time. We keep using the term data, which I find fascinating, because as a public health person, I think we're using data to mean a few different things. And I think specifically we refer to it in terms of quantitative data. And I think what we're talking about in terms of community insights may be the qualitative data, but I think what we're really aiming for is beyond that, and actually co-production, equal partnerships, being led by, working with, alongside communities. And for me, the crux of that is what Santosh said, which is about humility. I guess, having been an orthopedic surgeon when I started out my clinical life, I learned very, very early on that lesson about humility. The quantitative data could tell me so much, for example, about somebody's fracture. You could plan the most specific, angles, the most specific treatment, the most specific procedure. But then I found, many, many times somebody would say, well, we don't want that, so I don't want it. And when you get down to the bottom of that reason, there are so many things that contribute. from fear, from somebody not knowing what's going to happen to the house, from somebody being worried about their cat and not wanting to leave them uncared for. Those are the kind of things that data can't show. And those are the kind of things that absolutely depend on humility. And I think, having worked as a commissioner, that the worry and fear in my mind has always been data can be used in a very simplistic way as a tool for measurement. So I guess in terms of health creation, I had 4 asks, and Maren, maybe to build on your 4 Is. The infrastructure bit, I'd like to see health creation seen as a lens, as a mindset. The intelligence bit, I'd like to see us getting intelligent about the way that we use data and information in terms of seeing its limitations and also its potentials. In terms of interventions, I'd like to see it as an ongoing thing, because in the world of complex systems, and I do a lot of work in terms of leadership and organizational development, actually the interventions aren't, as Dan has said, you can't take a blueprint and play it in another area. It becomes about test and learn. We've seen so many times it begins to be about co-producing, taking risks, hearing things, holding ideas that may be very different from our own and giving things a go. That's a very different way of being and often is quite fear-inducing. So it's something for me about how do you help the health and care system to be able to work in that way? And that's been my focus of my work over the King's Fund. And the last thing for me is about incentives. I absolutely agree about the incentives, both for the communities and for the people doing this work. For me, there's a bit about how do we really make sure that's for the long term? And also, how do we understand the other incentives that exist? Financial is absolutely key, absolutely, and too easily overridden or forgotten. But actually, there are small incentives along the way as well that mean so much. So there's something about how do we bring that into our conversations and our nuances as well. I'll leave that for now. I've chucked a lot at you, but thank you for inviting me to join today. It's been a wonderful discussion already.
Thank you so much, Dirka. That's really challenging, and I think those, those new insights into those 4 Is is really helpful. Nigel, again, if you could say a little bit about Solace, so explain where you're coming from, and perhaps as part of this whole population health management question, why do we need private companies to be doing this data? It looks as though Cumbria and Lancashire have managed without an organization like yours. So say something a little bit about that, perhaps, and whether it does or does not affect, the data that you collect and the use to which it's put.
Well, there's a challenge. Thanks for that, Brian. So before I address that very reasonable question, I might add, just a little bit of context then. So I'm Nigel Sloan. I'm the CEO of Solace. We're a health analytics company, which I established about 27 years ago now. Prior to that, I had 10 years working within the system. Started as a management trainee back in 1983, which explains a lot of my grey hairs. So I've seen a lot on this health and care journey. In answer to your question about the private sector and what we can offer, and this is based on that 27-year experience and more recently experience working with NHS England on that population health development programme, which Dan referenced earlier. I think it's pretty uncontroversial to say that not all the places that I have been working with, and I have been actually in the room facilitating workshops, action learning sets with all sorts of interesting people from different places across the country. So I've seen lots of shapes and lots of sizes. Not everybody is a West Lancs and Cumbria. There are examples of fantastic best practice out there, which Andy and his team have articulated so brilliantly this morning, but they are the exception and not the rule. That would be my immediate sort of feedback from the work that I've been involved across the place. And whilst it is absolutely true to say that the NHS in particular, and local government to an extent, has some brilliant data whizzes, such as Andy and his team have got access to. There are issues there about capability and capacity, and I think where those issues are in situ, and I see them in lots of different places, people trying to do good, important things very quickly, there is a requirement often for support from the private sector just to get people quicker from A to Z. So I'm very much a small medium enterprise. I'm not an IBM. I'm not a Cerner. There's there's half a dozen of us. We don't want to take over the world. We don't want your data because we're going to sell it off to large American insurance companies. We don't want it because we're going to build a multinational empire, which is going to be a global significance. God knows, 27 years ago, if I'd wanted to do that, I wouldn't have chosen the NHS as my key market. We do it because we genuinely believe we understand the issues that the health and care system is currently faced, and we believe that we have skills and experiences which can make a difference. So, ours is a complementary offer, if you like, to what people in the health and care system are trying to build in-house. We're trying to support, help people up, as opposed to take it all over. That is absolutely not our goal. And having done this data stuff for 27 years, we'd like to think that we've got something to share there. But I absolutely take the view that we should not obsess here about the data. It would be somewhat heretical of me, wouldn't it, as a CEO of an analytics company, to say it's not important. It is, and we can't do population health management without it. But those cultural shifts, which Dan spoke so eloquently about, are absolutely critical. And just an observation, if I may quickly, again, it goes back to that facilitation work I've been involved in with different places across England, working on that PHM program. And to Dirk's point as well, and I would absolutely support it, there is an obsession, and I think that is the right word, with the collection of quantitative data. And boiling the sea in terms of our efforts to secure that data, which isn't often easy. It has proved challenging, and it remains a challenge in certain places. But this obsession that once we've got this quantitative data, then the answer to that is just to curate a beautiful series of dashboards and throw that out to people and expect them to act on what those technical dashboards are telling them. And my experience teaches me, and it's a mantra I continue to posit in-house at Solace, is the road to hell is often paved with dashboards. And some of that is related to the fact that, and I am minded of a story, if I may share with you, with a PCN clinical director I was working with in the south. It was in Surrey, I think. And we had done some work around dashboarding based on a linked primary and secondary care data set. And we know from experience that if we can get those data sets and link that data, we can provide some powerful insight, particularly around the scale of multimorbidity which exists within a geography. And we did our latest and greatest technology work, and we threw out these dashboards, and I felt very pleased with myself, as did my team. And the PCN clinical director just stopped me in my tracks and said, "Mr. Sloan, very pretty graph, 2 questions. A, what does it mean? And B, what the hell do you want me to do about it?" And I think those are excellent challenges to companies like mine. We have to be part of the story about what it means and what are the options available to me, in this example as a PCN, to make a difference to the communities that we serve. So if you are a technology company and you cannot answer those questions credibly, then really you shouldn't be, you shouldn't be in the room, is my humble opinion. And that's based, honestly, that's based on 27 years of me curating those dashboards and throwing them out and saying, aren't we clever? I think hopefully we've learned over that 27-year period that is not necessarily the answer. And again, if I may,
I need to wrap up, Nigel, please, if that's okay.
Not at all. But again, it goes back to the importance of that qualitative data, which Dirk and others have spoken about. We need to find out what's really happening in people's lives, and those dashboards don't tell you that.
That's very, very helpful, and thank you for answering my question, Nigel. That's very helpful indeed. Andy, I'm afraid we have to move on to the breakout rooms now to give more chance for people to talk and to work things through. I think it would be helpful to, again, Ollie seems to be asking very key questions. If it were possible to think, how would a system have to operate so that Azmina could feel comfortable about sharing her data? That might be an interesting and useful question to address in the breakout. So let's go into the breakouts. I think the questions that we have to answer are there on the screen. Do you know of any data sharing of community narratives and quantitative insights between systems and communities? How is that working? Would you like the national programme to develop along the lines proposed by Health Creation Alliance and Lancashire and South Cumbria? And what do you think of the proposed call to action for ICSs? Do you think it could be improved? So let's go into the breakout rooms and see you later.
Just to let everyone know, you've now been, the breakout rooms have been open, so you'll just need to accept the invitation to join the breakout room. You'll have 15 minutes and then I'll give you a 5-minute warning.
Welcome back, everyone. Thank you very much, Neil, for making all of that work so slickly.
My pleasure.
So we have very brief time for feedback. I don't know how many groups there were, but I can certainly talk about.
There were 4, Brian.
Okay. So I can certainly say a little bit about what we talked about, which was very wide-ranging in a very short space of time. There were lots of examples of sharing and comparing data, so there's obviously quite a lot of that around, sort of straightforward sharing across different sectors that seem to be working quite well, and there seem to be IG arrangements whereby it is possible to identify individuals by clinicians through that data. So that did sound like it was quite possible. But I think what really was striking in our group was not only the issue about inequity and justice, which I think as the Health Creation Alliance, we do need to think further about, but also that the social determinants of health are extremely difficult to talk about. So if we are talking about justice and inequity, if we are not able to talk about poverty, for instance, then that makes life extremely difficult. And it does appear that in some places, in fact, in many places, that sort of approach is not regarded positively. So that seems to be quite an important element that we have to think about and challenge. So who's in the next group to come back with a brief feedback? Group 2.
Would you? I don't know. Do we have numbers? Would you like me to go next, Brian?
Yeah,
I don't know if it's group 2 or not.
Please.
First off, I'd like to thank my group. It was such a good chat. I'd like to talk to them all longer. But just to unpack, we talked a little bit about something that's been going on in the chat column whilst we've all been talking today, which was about, like, there's no pill for poverty. There's no talking therapy that fixes your washing machine. So sometimes the data and the information that we find out shouldn't just become an automatic route into the NHS's mental health crisis management and pills and all these things. If the intelligence is telling us it's driven by a social problem, then we need to make sure the tools and the information's around for, you know, clinicians to signpost on. Asmina talked a bit about how questions are asked. I hope I'm getting this right, Asmina, jump in and correct me if I'm wrong. But, you know, like her community was asked on the premise of vaccine take-up and particular areas of the faith sector not having great take-up. And actually, if I understood her right, she felt that was a question about race rather than about faith, and that sometimes how these things are handled are just not very culturally sensitive, it sounded like. So I think we need to be conscious of how we deal with every community and what's important to them, and not just going blindly asking blanket questions. And then we talked a little bit about the dangers of data. I mean, we don't want to be too negative, but there are organizations that come with a dual purpose. You know, a few of us have come across them, and they could be social enterprises or they could be private sector organizations. It doesn't really matter, but there are organizations that collect data about social determinants, about people's problems, and then actually sell that data on. So there is a little bit of fear about that. Although we did acknowledge that, you know, the company that we're in today, everyone here seems to have the right ethics and the right values. So we're all confident in working with each other, but just a bit of word of caution that there are some out there that may not be like us. And then we talked a little bit about what isn't collected. So, for example, social prescribers, frontline workers at Citizens Advice Bureau, housing officers, people that are, you know, that are at the coalface. They're having these deep, rich conversations where people are revealing really challenging circumstances. And then actually, there isn't really a system to act on that quickly. So our NHS systems particularly are not set up if somebody says they're not going to eat within the next 3 weeks. So it's one thing to collect data and information, and it's good to collect that data about what people are actually facing, but then we must have an adequate response behind that, otherwise it's pointless. And then I suppose as a final point would be, we always seem to start with the NHS data and work backwards. So if we had the sort of a rallying call or a request or a way forward, it would be to try and start with the voluntary sector data and the faith sector data, and, you know, the data in my street, which actually might not be traditionally what we call data. It might just be about having a conversation and insight and intelligence, really. So that was my group, and it was
thank you very
enjoyable.
much.
Thank you,
Chris, very helpful. Very briefly, the next group, if possible.
Yeah, we've got Maren and Nigel.
I'll go next if you like, and leave the last to Nigel. We were all agreed that we would like to see all ICSs doing it in the way that Andy's team's doing it, and in the way that the Health Creation Alliance is suggesting that we should do it, and obviously develop that further. We agreed that people need to have some probably protected and funded space to do this, so they can have time out of their clinical jobs. Otherwise, it's always being fitted around. But also space came into it again in terms of physical space. So, you know, spaces where sort of the formal and in the formal services and communities can meet, where communities feel comfortable, and NHS Property Services was in our session, so that helped bring that in. But we also said, why is it that NHS England doesn't make this explicit on its website and in all its programmes? Why isn't Health Creation in all of that already? And we came to the conclusion that it kind of is in little bits articulated in different language, different places, different ways of thinking about it, coming in a bit to personalised care, a bit in Neil Churchill's team. And of course, you've got Olivia's team there doing it. And Durka said she's trying to join it up. And I said, well, Health Creation Alliance is presenting a way of describing this that then can go into each of those areas. So we're also trying to join it up. So perhaps we can work together on that.
That's brilliant. Thank you so much, Merran. And sorry, who was last?
I think it's me, Brian.
Yeah, go ahead, Nigel.
Got that right? Yeah, I will keep this brief, I promise, because I know you're now short on time. A couple of things then, really. Yeah, really pleased to hear, Brian, that your group had such positive experiences of data sharing, and that data is flowing, and they are able to act on that. I have to say that wasn't necessarily the experience of the group that I was working with. There still remain significant IG challenges out there which need facing down. And from my perspective, that becomes an issue of leadership and courage. The leaders in the system need to make that happen. Because whilst that data isn't the be all and the end all, and it won't give you all the answers, it is part of what we're trying to do here. And it has the capability to provide real insight to make a difference to people's lives. And we've heard that this morning from our friends in Morecambe Bay, haven't we? And to that point, we do absolutely need to look beneath that quantitative data and go out into our communities and talk to people. Because if you do that, and we had a brilliant example in my group, if you actually go out and then talk to people off the back of that data, you will learn things you didn't know from those dashboards, and you will then change services and improve people's lives for the better. So don't believe everything the dashboards are telling you. They're a guide. Go and speak to people. They're human beings.
Thank you very much, Nigel. Well, I'd like to wrap up now. Thank you so much, everybody, for your involvement, your interest, your energy. It's been really an exciting session, very challenging and very insightful, really very much appreciated. I'd like to remind us about our sponsors and to say thank you very much to them for making this possible and this whole series possible. National Health Executive and Public Sector Executive, HLM Architects, NHS Property Services, Novartis, PPL, Solis, South Central West. Don't forget you can join the Health Creation Alliance. The evaluation, please complete it, and let's go forward. Let's make population health management a data with soul. And we look forward to that changing and to improving across NHS England. Thank you very much, everybody. It's been a great session, and we're very impressed with all of your involvement and your support. Thank you so much. Safe journey home, wherever that is. Take care. Bye-bye.